Hi, good evening, everyone. My name is Astrid Schellners-Faure. As a member of Educational Committee, I am honored to be speaking at this second webinar of the year. Firstly, I would like to welcome you all to the webinars. This event brings together experts and professionals to share knowledge, ideas, and best practices in immunology. And today I will be presenting Camila Francisca Downey Saldivia on the topic of cutaneous manifestation of autoinflammatory syndromes. Dr. Camila Francisca Downey Saldivia, she is medical surgeon from the University of Chile and specialized in dermatology from the Pontificia University Católica de Chile. Dr. Downey Saldivia completed her training in pediatric dermatology at the Universidad Autónoma de Barcelona. She currently works at the Luis Calvo Maquena, Clínica Alemana de Santiago, and Clínica Hemangiomas. She is an assistant professor at the Faculty of Medicine of the Universidad de Desarrollo and Faculty of Medicine of Universidad de Chile, and she's currently the coordinator of Pediatric Dermatology Group of the Chilean Society of Dermatology. She also has completed professional training stays at the University of Leiden, Netherlands, Harvard University, United States, and Santa Cruz San Polo Hospital, Spain. Thank you very much, Dr. Camila Downey Saldivia, to share with us this presentation, and I will give you now your time.
Thank you so much, Astrid, for the introduction. I realized in the flyer when I was saying it now that it appeared that I worked in Universidad Católica of Chile, but I studied dermatology there. And as you well said, I'm currently working in Clínica Alemana and Hospital Luis Calvo Maquena. So thank you very much for the invitation and for the introduction. I'm going to share my screen now. So please, you can tell me, Astrid, if you can see it properly.
Yes, perfect. Yes, we can see it. Thank you.
Okay, thank you. Thank you very much for the invitation today. As we were saying, today we're going to speak about cutaneous manifestation of autoinflammatory syndromes. In this topic, I've learned a lot from you, from the pediatric immunologist. So I hope I can give you back some of the things that I think that will help you on the day-to-day basis on these patients. This is the roadmap we'll follow for this talk, for which I don't have any conflict of interest to declare. We will talk about what are autoinflammatory syndromes, why it is important to know them, how do we suspect them through skin lesions, how we diagnose them, and how are they managed. So what are autoinflammatory syndromes? You know better than me that these conditions are part of inborn errors of immunity. And why don't we doctors know them that much? It is mainly because they were described so recently. It was just in 1989 when Dr. Janeway at Yale proposed a theory of how the innate immunity would work if it existed. And in 1995, his same group described that there is a toll-like receptor that activates innate immunity. And in 1999, in the NIH, it was described germline mutations that cause familial autoinflammatory syndromes of dominant inheritance. So since 1989 till nowadays, a lot has happened. We've learned a lot, and nowadays we know very well how the toll-like receptor is structured, how it works, and these things have these conditions when they were first described. Only a few conditions were described till 2014. But if we see the timeline, after 2014, an explosion of new pathogenic variants in autoinflammatory syndromes were described. So it's very hard to keep track of all the lesions all the pathogenic variants that have been described. And why do we think, or why do we don't know them that much? Maybe us that see these conditions that are very rare we that see pediatric patients are more aware of these conditions. But the doctors that see adults nowadays, they are also seeing patients that they had the first manifestations in childhood and they were not diagnosed properly. And also there are some autoinflammatory syndromes, as syndrome, that they debut in adulthood. So all doctors, the ones that see children and the one that see adults, should be aware of these conditions. So how do we as physicians raise suspicion for this diagnosis? It is clue to make a very good medical history and perform a detailed physical examination to raise the first suspicion for this diagnosis, because it's not easy to make the diagnosis from the clinic because we don't have established criteria for these conditions. But there are some signs that can be suggestive or red flags where we have to suspect that we might be in front of an autoinflammatory syndromes. And these are recurrent episodes of sterile inflammatory manifestations that they last more than 6 months, that these patients have elevation of acute phase reactants, that they can have other family members affected, that there may be consanguinity, that these conditions start very early in life, and that may have multiple organ involvement simultaneously, including the skin. So how can the skin help us in the diagnosis process of these patients? Skin signs may be the first manifestation of an autoinflammatory syndrome, and recognizing the types of cutaneous manifestations and their associations can guide us to the diagnosis. But how do we classify them? How do we put them in a way that it's easy for us to approach the cutaneous lesions? The cutaneous lesions associated with autoinflammatory syndromes are so heterogeneous and busy as this slide. So how do we classify them? The classical way of classifying autoinflammatory syndromes is through its pathophysiology into 4 big groups: the groups that have pathogenic variants related to the inflammasome, the ones that have mutations in the interferon pathway, the ones related to misfolded proteins in the endoplasmic reticulum, and the ones that are related to the NF-kappa beta pathway. And in this pathway, lots of conditions have been described. You can see here in light blue and in orange all the conditions that have been described related to the inflammasome, and the ones that have been described related to the interferonopathies. So what do we do with all this information as physicians? The first thing we tend to think is that our mind is going to blow up because it's too much information, are very rare conditions, so we will probably not see these conditions, but I'll bet that the condition has seen you in more than one case. So let's take a deep breath and look at the classification in a more simple way. If we classify the autoinflammatory syndromes in 3 big groups, the inflammosomopathies, the interferonopathies, and the NF-kappa beta pathway-related conditions, we will see that the 3 groups may present with fever, may have organ involvement, and other manifestations. But when we see the skin manifestation, they're not the same in each group. For example, in inflammosomopathies, we will see non-vasculitic rashes. We may see erythematous plaques that resemble erysipelar cellulitis, urticaria, or pustules. And if we are in front of an interferonopathy, probably we will have vasculitic or vasculopathic lesions or rashes. And if the pathway is affected, we will probably find ulcerations and granulomas. And why is this important? Because here in Latin America, we don't have the chance in many cases to do or to perform the genetic testing right away, and we have to make therapeutic decisions. And these findings may help us to orientate our diagnosis and choose with which therapy we will start. So Dr. Torello from Spain, that is a pediatric dermatologist, proposed on this classification based on the dermatological manifestation. And here you can see that For example, when we have vasculitis, we can induce which syndromes we are in front of. So getting to know which are the clinical manifestations may be a very good tool for us to make the final diagnosis. So the classification based on the skin manifestations are 9 groups that I will try to present to you in clinical cases, because I think that this is the way that we deal with patients on the day-to-day basis. So this is the first case. This case is a 34-year-old woman who came to the clinic with a 4-year history of this erythematous plaques that is very bright and well demarcated. That the first time that she had it appeared with fever, with acute phase reactant elevation. So the first thing that was thought, and that is what should be thought as first, was a cellulitis or an erysipelas. So she was treated with antibiotics and the lesion went down. But she tells that 3 other episodes with similar manifestation has appeared with no pathogenic germ isolated. So this is the 4th time that she comes here with acute phase reactant elevated and no bacteria or viral infection isolated. So a skin biopsy is performed in this patient. And what we see here is that the epidermis is normal, but in the dermis, we see edema of the papilla with superficial and deep infiltrate of lymphocytes, but mainly neutrophils. So when we have a lesion that resembles or reminds us of a cellulitis or erysipelas in a patient where we have the suspicion of an autoinflammatory syndrome because there's no pathogenic agent that has been isolated, and we find neutrophils in the biopsy, we have to think that we might be in front of an autoinflammatory syndrome. And the classical one that presents with this manifestation is familial Mediterranean fever. And these erythematous plaques have also been described in another syndromes like TRAPS or hyper IgD or Aura syndrome. And these are all the syndromes that have been, the autoinflammatory syndromes that have been described related to maculopapular eruption or inflammatory plaques. Different is the case when we have hives. This is a patient, a 29-year-old female patient, that she tells us that she has had hives, recurrent hives, since she was 2 years of age. In dermatology, when we have a patient with hives that last more than 6 weeks, we think that we're in front of a chronic urticaria. But urticaria lesions classically last less than 24 hours. But when this patient was asked how long these lesions last, she was sure that the lesions last more than 24 hours. And the lesions appear with fever. All the cultures are negative, elevated acute phase reactants. And these lesions were also biopsy, and they were consistent with urticaria, but with a neutrophilic infiltrate. So when we have an urticaria with a neutrophilic infiltrate, and if it happens on early childhood, before 6 months of age, or if the patient tells us that these lesions are triggered by cold, we can think that we are in front of cryopyrin-associated periodic fever syndromes, also known as CAPS. And also in these 2 pathogenic variants, we can have urticarial exanthems as the main presentation for these autoinflammatory syndromes. And these are the main autoinflammatory syndromes described with urticaria's presentation. Another lesion that we see often in these conditions are pustules. Pustules are vesicles that are filled with pus. We see them often in acne in teenagers. And this case is the case of a 23-year-old that had recurrent pustules on the extremities and in the face, and also had some ulcers. And these recurrent episodes appeared with fever, with malaise. All the autoimmunity exams were negative, and never an infectious disease was isolated. So when we're in front of pustules and we have high suspicion for an autoinflammatory syndrome, we might think that we are in front of this pustular pyogenic or neutrophilic dermatosis like eruptions. And when we have these pustules that can be, as we see here in a neonate, we have to think that we might be in front of a deficiency of the interleukin-1 receptor antagonist, also known as DIRA. But when the lesions resemble pustular psoriasis, we might be in front of a different autoinflammatory syndrome that is called DITRA, that is related with the interleukin-36 receptor. And when we have a pyogenic granuloma filled with pustules, we can also think that we are in front of autoinflammatory syndromes. And the autoinflammatory syndromes that have been described related with pustules are many, and they are written here in this column. And so it's very important when we have pustules that don't fit another diagnosis and we have recurrent fever, affection of another organs, we can think of autoinflammatory conditions. And what these three types of presentations have in common: the erysipelas-like lesions, the urticarial lesions, and the pustules. What they have in common is that they have elevated interleukin-1 or 18 or 36, that is the same pathway that can respond very well to interleukin-1 receptor antagonists or interleukin-36 receptor antagonists. So it's very important when we have these three manifestations associated with fever or the other anti-inflammatory symptoms to think about these conditions. Very different is when we have nodules. This patient is 12-year-old patient that present with a 6-month history of a dry cough and nodules on his legs. And this patient had also a chest CT with an interstitial infiltrate. And when we have an adult that has cough and has this lesion and has alterations on the CT, it's not hard for us to think of sarcoidosis. But when these lesions appear in the in childhood period, we may think that we are in front of a Blau syndrome or early onset or early onset sarcoidosis. And the manifestation may be these nodules, but also can be very infiltrated papules, as we see in this picture, that when we biopsy these lesions, they are granulomas. And the other autoinflammatory syndrome that can present with nodules is a syndrome called Candle, that it can present a special type of nodules that are annular violaceous nodules on the trunk that is associated with this lipodystrophy and with periocular edema that reminds us of dermatomyositis. This syndrome was described by this Spanish dermatologist that I told you about, that is Dr. Antonio Torrello, with whom I had the chance to rotate with last year. And one of the things that I learned while being with him is that the manifestations are not only in Candle syndrome, the ones that I just told you, but also in the neonatal period, in early infancy. Just look at these toes. When we have pearl-like lesions in a newborn with fever, we have to think about interferonopathies. This is a hallmark of these conditions. These pearl-like lesions in neonates can be seen in Savy syndrome, in Aicardi-Gouttières syndrome, in familial lupus, and are lesions that when the patient grows, they tend to sometimes to go away, to fade, and these other lesions start appearing, these plaques and nodules on the trunk, and then in the last phase, the lipodystrophy appears. So this is one clinical tip that I would like you to recall, that are the perennial lesions on infancy, and remember of interferonopathies. So when we have nodules, subcutaneous nodules or paniculitis, we have to think of Blau syndrome. We can think of Candle syndrome and also knee-modulating XN5 autoinflammatory syndrome. Let's go to the next case. The ones of you that have read this paper probably will know which syndrome I'm talking about, but it's one of the best examples in the literature about what do we have to think when we have a child that has this malar rash that reminds us so much of lupus. And when we see the hands or feet, we can see papules, we can see pernio-like lesions, we can see some ulcers. And if this patient is biopsied, probably we will find not a vasculitis, but an occlusion of the blood vessels. And if this child also has some respiratory symptoms, we can also find an infiltrate on the chest CT. So all these lesions together, and if this child also has fever or elevated acute reactant, we have to think about Savy syndrome. And what's the relevance of thinking early about Savy syndrome, that is this interferonopathy? That if these patients are treated early, for example, with baricitinib in the neonatal period, we can avoid this evolution because this is the spontaneous evolution of this condition that evolves with necrosis, with amputation of the distant phalanges, and of course, with a very low quality of life for these patients. So the high suspicion in these patients to insist with genetic testing is very, very important in these patients. And the other autoinflammatory condition that we can see with vasculopathic lesions is the one that you can see here on the right. When we have these lesions that are tram-like reticulated violaceous lesions that are called livedoreticularis, that if you ask the patient, they don't go fully away with heat and that they are persistent. And if we biopsy these lesions because they've been there probably more than 2 months, what we will find here is a medium-sized vessel vasculitis consistent with PAN. So when we have this medium vessel vasculitis in this presentation of livedoreticularis, we have, even if we don't have many systemic symptoms, we have to have the suspicion of a deficit of ADA2. And in these patients, we have to go and look for vasculitis in the central nervous system or in other organs and do a full workup and start treatment if it's necessary. Many syndromes, as many as the ones described in this slide, have been described with vasculitis or vasculopathy as clinical manifestation, but interferonopathies are one of the biggest groups and the most important and more easy for us as dermatologists to think that we're in front of these conditions when we see them, because they're very uncommon as other presentations in childhood. And vesicles are manifestations that are not that often seen in autoinflammatory conditions. And when we have vesicles and when we have inflammatory bowel disease, we have to think about the syndrome that is called a plaid. A plaid appears where these vesicles in very early childhood can have inflammatory bowel disease, and it's the classical autoinflammatory syndrome that manifests with vesicles. Another type of manifestation that is very uncommon but is very special is the one that we find in H syndrome, when we find hyperpigmented infiltrated plaques that can have a hypertrichosis in a patient that has short stature or developmental delay. We have to think about this syndrome that is called H syndrome. And very uncommon also are the hyperkeratotic lesions that are seen in IH syndrome. So hyperkeratotic, hyperpigmented, and vesicular lesions have been described in these three syndromes, and are very important for us as clinicians to be aware that this can be a clinical manifestation of an autoinflammatory syndrome. And to finish, this is the last case. It's a 39-year-old woman who has a history of oral ulcers since 2 years of age, genital ulcers since 20 years of age. And in the last 3 years, she has had pustules, vesicles, and uveitis. If we see an adult with these lesions, the first thing that might be diagnosed is Behçet's, but these patients did not respond very well to the usual treatment. So when we have a patient with Behçet's that had very early onset and did not respond as we expected, we may think that probably we will have a mutation in BRELA, and this mutation can have a special treatment and help the patient a lot with the symptoms. And in all these three other syndromes, also ulcers have been described as one of the main clinical manifestations. So those lesions are not that uncommon in autoinflammatory syndromes. So when we have fever and after those lesions, genital or oral, we have to think about these conditions. So this is some summary of, if you see here, if we approach the patient from the skin lesions when we have a suspicion of an autoinflammatory disease, the type of skin lesions help us go through a pathway that can end up in proposed of a possible syndrome. For example, if we have erysipelas-like lesions that start symptoms in childhood, that is accompanied with periodic fevers, synovitis, pleuritis, and peritonitis. Even if we don't have the lab test, we can think that we are probably in front of a familial Mediterranean fever syndrome. And this is what happened with all the other manifestations that I have shown you today. So this is how we approach, or this is how we have a high suspicion of these conditions. But how do we diagnose them? After making this good medical history, a detailed physical examination, we perform lab tests. But in these patients, besides an elevated acute phase reactants, we may not have anything else. Probably all the autoimmune exams will be normal. So what we aim to do in these patients to have the final diagnosis is a genetic study. And in Chile, we have I have the luck to work with Dr. Cecilia Poli. That is one of the biggest reasons that I'm here today with you in the Gen8 project. And what we do with our patients today, after all this, after seeing the clinical manifestation, is that we enroll these patients, and these patients come through this pathway where we perform the genetic testing. If they have a variant that has been described previously, we can help them to have the diagnosis and continue with their treatment. But if they have a novel variant, or they only have variants of uncertain significance, we perform an inflammatory pathway characterization of these patients. And once we have a candidate gene, we try to make the validation to establish the causality in these patients. So after performing functional genomics, we aim to discover novel genes, variants, and inflammatory pathway associated with this autoinflammatory conditions. And nowadays, I can show you that from the patients that we have that are around 100, but when we performed this chart, they were about 80. We have 18 with known genetic diagnosis that have the clinical manifestations that I have told you today, but we still have like 55 patients that don't have yet a genetic diagnosis. But of these 55 patients, 45 have dermatological manifestations. So grouping them in different in these clusters may help us to make the therapeutic decisions while we wait for the definitive genetic diagnosis. And how do we treat them? When we have these three groups, we can induce which are the cytokines that are involved in this process. So when we have lesions or when we have conditions that are related with the inflammasome pathway, we will probably decide to use an interleukin-1 inhibitors such as anakinra or canakinumab. And when we have an NF-kappa beta pathway affected condition, we will probably choose to have to use TNF inhibitors. And when we have the pathway of the interferon affected, we will probably choose JAK inhibitors. And nowadays we have so many medications available. Still, we for some conditions we lack treatment, but now we know that many of these conditions in dermatology and immunology can be used in these patients. And in inflammosomopathies, as I told you, what has been chosen is the interleukin-1 blockade. This is the chart that shows how well DIRA responds to canakinumab or to anakinra. The response in these patients is really spectacular. If you start this after seeing the multiple pustles, you perform the genetic testing, the genetic test story. Sometimes you have it in 3 weeks, for example, you start anakinra, and these patients, all the lesions most of the time fade away, and these patients do very, very well on this medication. Different is what happened with the patients with DITRA that had mutations in the interleukin-36 receptor, and this is why spesolimab was developed, because these patients did not respond that well to canakinumab or to anakinra. And spesolimab, now we have it in for clinical trials, and it's coming to the clinical use, and we hope to have it in our country. And when we have interferonopathies, we in the last 6 years, 6 years, a lot of more experience regarding to JAK inhibitors have been developed. JAK inhibition, for example, with baricitinib, has shown to be very effective in patients with Campbell, with SAVI, with Aicardi-Goutieres syndrome, improving the cutaneous lesions, also besides systemic manifestations. Many studies have shown that this medication improves quality of life in patients, improve the evolution of the condition. And recently, anifrolumab has been developed. This interferon alpha inhibitor has been developed originally for lupus, but has been used lately for dermatomyositis and for SAVI with very good results. And when we have affection of the NF-kappa beta pathway, the TNF blockade in patients with ADA2 deficiency has shown to have very good response also. So my message today was that skin signs may be the first manifestation of an autoinflammatory syndrome, and that recognizing the type of skin manifestation can guide the diagnosis, and that today we have specific targeted therapies for some of this condition, and sometimes we don't have the genetic results right away. So maybe thinking that we're in front of these clusters may help us to make therapeutic decisions that can help our patients improve earlier in their evolution. So thank you very much for your attention. I hope that this talk was of help for you. And thank you again so much for the invitation and for being here.
Thank you very much. That was very, very clear. And I think it has helped us a lot to classify skin manifestation and understand the disorders and adjacent clusters. So it has been very, very helpful for us. As you said, after 2014, there was an explosion of new variants, and now we have a lot of new mutations and variants that we have to classify every day. And well, I think it was a very interesting presentation. Thank you very much. Just looking after some questions on the chat. I don't see any question, but maybe I have one. I think sometimes it's very difficult to look after a JAK inhibitor for interferonopathies, to choose one of them. maybe ruxolitinib or baricitinib, there is in the literature, and sometimes it's very difficult to us to choose one of them. Do you have any experience about that?
When I was in Spain, what I saw is that what is being used more in children, and not only in autoinflammatory syndromes, but in other dermatological conditions such as alopecia areata or vitiligo, is baricitinib. Like today, we have more experience of its safety in children, and especially in autoinflammatory syndromes and interferonopathies. I saw that this medications were started like in the neonatal period with very good tolerance, and for example, in the case of the perineal like lesions or the ulcers that develop to necrosis, baricitinib was able to like stop this progression. But and ruxolitinib, we have more experience in Chile because of age in hematopoietic cell transplant patients, and in dermatological conditions we use it mainly in pansclerosing morphea, and it also has been used topically in alopecia areata. So sometimes in our hospital it's easier to get ruxolitinib because we have it in the arsenal for oncological patients more than baricitinib. So sometimes we end up using that one.
Yes, the same for us. Yes, and I think it's very important to look always after the TBC for our patients, because we have a lot of TBC before to start the treatment, and maybe this is different in Europe, one country. But yes, it's the same for us. It's easier to look after ruxolitinib, and but sometimes it's this the way we choose. But maybe okay. Well, I don't see other questions on the chat, but I am very happy to listen your presentation. It was really very interesting. So thank you very much for your participation. I have some announcements by the end, some ads for our. So we have some dates to remember. I will talk now in Spanish, so it's easier for me. Tenemos próximamente Congreso de Inmunodeficiencias Primarias el 27 al 29 de marzo. Para recordarles a quienes quieran participar. Y aquí tenemos el link para inscripción y el QR. Aquellos que aún no han podido inscribirse y desean hacerlo. También tenemos en Brasil, del 25 al 26 de abril, para también quienes estén interesados en participar, están abiertas las inscripciones. Aún hay cupos para participar. Y bueno, y por supuesto, nuestra gran fecha, la SID Meeting en octubre aquí en Buenos Aires, que están todos invitados a participar, y esperamos encontrarnos en estas fechas en Argentina. Y creo que por último, a quienes quieran participar y ser miembros de la SID y no lo han sido aún, es de forma muy fácil. Pueden aquí escanear el QR y fácilmente pueden ser miembros de la SID. Así que bueno, muchísimas gracias. La presentación ha sido de gran ayuda para nosotros, con una gran visión desde el aspecto dermatológico y que nos ha ayudado muchísimo en nuestra práctica médica.
Gracias a ustedes, que tengan muy buena noche. Adiós.
Adiós.